You are climbing the stairs to your apartment, the same stairs you have climbed thousands of times, and somewhere around the 4th floor you have to stop. Your chest feels tight. Your breath comes in shallow gasps. Your legs are heavy, not from muscle fatigue, but from something deeper, something that does not make sense because these stairs never used to bother you. You lean against the railing, waiting for the sensation to pass, and when it does, you continue to your door telling yourself you're just tired, just out of shape, just getting older. A month later, you wake at 3 in the morning unable to breathe. You sit up in bed gasping, and the strangest thing happens. The breathlessness improves. Lying down made it worse. Sitting up makes it better. This makes no sense to you. Why would position affect breathing? You prop pillows behind your back and eventually fall asleep sitting upright, and in the morning you wonder if it was a strange dream, except your pillows are still stacked and you are still sitting. Your ankles have started swelling. Your shoes feel tight by evening. You gained 4 pounds in a week without changing how you eat. You notice that your heart sometimes flutters or races when you're doing nothing at all. You feel exhausted in a way that sleep does not fix. Each symptom seems minor in isolation. Each one has a reasonable explanation. Fluid retention, maybe you ate too much salt. Fatigue, maybe you're not sleeping well. Breathlessness, maybe you need more exercise. You do not connect these scattered signals into a single picture because you do not know they share a common source. Your heart is failing. Not suddenly, not dramatically, but gradually, incrementally, in a process that may have begun years or even decades ago. The organ that has beaten without rest since before you were born, the pump that sustains every cell in your body, is losing its ability to do its job. And because the decline is slow, because your body compensates for losses you cannot see, you may not realize what is happening until the failure has progressed far enough to limit your life in ways that become impossible to ignore. This is what I want to explain: how the heart fails slowly, what happens inside your chest as pumping power diminishes, why the symptoms you experience make sense once you understand the mechanics, and what can be done to slow the progression, manage the consequences, and maintain quality of life even when the heart cannot fully recover. Let me begin with what the heart actually does, because appreciating its function is essential for understanding what happens when that function degrades. Your heart is a pump. This sounds reductive for an organ that carries so much symbolic weight, but mechanically it is accurate. The heart's job is to move blood. Every minute of every day it contracts and relaxes, squeezing blood out into vessels and then refilling with more blood to squeeze again. It does this roughly 100,000 times per day, 40 million times per year, billions of times over a lifetime. It never takes a break. It never rests. From the moment it begins beating in the womb until the moment it stops at death, it works continuously. The purpose of this pumping is to deliver oxygen and nutrients to every cell in your body and to carry away waste products for elimination. Your cells cannot survive without this delivery service. Your brain, your muscles, your organs, your tissues, all of them depend on blood arriving with fresh supplies and leaving with accumulated debris. When the heart pumps effectively, circulation is robust and cells thrive. When the heart weakens, circulation falters and cells struggle. The heart is divided into 4 chambers, 2 on each side, and understanding this division is important for understanding how failure manifests. The right side of the heart receives blood returning from the body, blood that has delivered its oxygen and collected carbon dioxide. This deoxygenated blood enters the right atrium, a thin-walled upper chamber that serves as a receiving area. From there, it passes through the tricuspid valve into the right ventricle, a muscular lower chamber that pumps the blood out through the pulmonary valve and into the lungs. In the lungs, the blood releases carbon dioxide and picks up fresh oxygen. This newly oxygenated blood returns to the left side of the heart, entering the left atrium and then passing through the mitral valve into the left ventricle. The left ventricle is the powerhouse of the heart, a thick-walled chamber that must generate enough force to pump blood throughout the entire body. It ejects blood through the aortic valve into the aorta, the main artery from which all other arteries ultimately branch. The left ventricle is thicker than the right because its job is harder. The right ventricle only needs to push blood through the lungs, a relatively short and low-resistance circuit. The left ventricle must push blood to the top of your head, the tips of your toes, and everywhere in between, overcoming the resistance of miles of blood vessels. This difference in workload produces a difference in muscle mass. The valves between chambers and vessels serve a critical function. They ensure one-way flow. When the ventricle contracts, the valve leading into it closes to prevent backflow into the atrium, while the valve leading out of it opens to allow blood to exit. When the ventricle relaxes, the outlet valve closes to prevent blood from falling back in, while the inlet valve opens to allow new blood to enter from the atrium. This coordinated opening and closing is what produces the heart sounds you hear through a stethoscope, the lub-dub that indicates valves snapping shut. The valves are anchored by structures called chordae tendineae, thin fibrous cords that connect the valve leaflets to small muscles within the ventricles called papillary muscles. This anchoring system prevents the valves from flipping inside out when pressure builds during contraction. When any part of this system fails, when valves stiffen or leak or prolapse, the heart's efficiency drops and workload increases. Heart failure means the heart can no longer pump blood effectively enough to meet the body's needs. This definition is important because it clarifies what heart failure is not. Heart failure is not the heart stopping. That would be cardiac arrest, a sudden electrical or mechanical catastrophe that ends life within minutes if not reversed. Heart failure is gradual. It is the slow loss of pumping capacity that forces the body to adapt and compensate until adaptation is no longer sufficient. The heart can fail from either side, and the symptoms differ depending on which side is primarily affected. Left-sided heart failure means the left ventricle cannot pump blood forward into the body efficiently. Blood backs up behind the failing pump. Where does this backup go? Into the lungs. Blood returning from the lungs to the left side of the heart encounters congestion. Pressure builds in the pulmonary veins, then in the capillaries of the lungs themselves. Fluid begins to leak out of the capillaries and into the lung tissue. This is pulmonary congestion, and it is why left-sided heart failure produces breathing difficulties. When your lungs are congested with fluid, gas exchange is impaired. Oxygen has trouble crossing from the air sacs into the blood. You feel short of breath, initially with exertion, later at rest. The breathing difficulty often worsens when lying flat because gravity redistributes fluid in ways that increase lung congestion. This is why you might wake gasping at night and find relief when sitting up. This is why people with advanced left-sided failure sleep propped on multiple pillows or even in recliners. The position matters because it affects where the fluid accumulates. Right-sided heart failure means the right ventricle cannot pump blood forward into the lungs efficiently. Blood backs up behind this pump as well. Where does this backup go? Into the veins of the body. The venous system, which returns blood to the heart, becomes congested. Pressure rises in veins throughout the body, forcing fluid out of capillaries and into tissues. This produces swelling, particularly in the legs and ankles where gravity pulls the fluid, but also potentially in the abdomen and liver. Left-sided and right-sided failure are connected because the heart is a single system. When the left side fails, pressure backs up into the lungs. This increased pulmonary pressure makes the right ventricle work harder to push blood forward. Over time, this extra workload can cause the right ventricle to fail as well. Left-sided failure often leads to right-sided failure. What began as breathlessness becomes breathlessness plus swelling, a progression that reflects the spreading consequences of an initially localized problem. Now let me explain what causes the heart to weaken in the first place, because understanding causes helps clarify prevention and treatment. Heart attacks are one of the most common causes of heart failure. When a coronary artery becomes blocked, the heart muscle downstream from the blockage is deprived of blood. Without oxygen, that muscle dies. Dead heart muscle is replaced by scar tissue, and scar tissue cannot contract. It cannot contribute to pumping. The heart must now accomplish the same work with less functional muscle. If the heart attack was large, if a major artery was blocked for a long time, the loss of muscle may be significant enough to tip the heart into failure immediately. If the heart attack was smaller, the heart may compensate initially but eventually fail as the remaining muscle wears out from chronic overwork. High blood pressure is another major driver of heart failure, operating through a different mechanism. When blood pressure is chronically elevated, the heart must push against greater resistance with every beat. The left ventricle, faced with this constant opposition, responds by thickening its walls, adding muscle to generate more force. This seems like a reasonable adaptation, but it comes at a cost. The thickened walls become stiff. They do not relax as well between beats. The chamber that fills with blood becomes smaller and less compliant. Eventually, the thickening reaches a limit and the heart begins to dilate, stretching out in a way that further weakens contraction. What began as compensation becomes pathology. The heart that grew stronger to meet the challenge ultimately grows weaker from the sustained effort. Valve disease contributes to heart failure through mechanical inefficiency. When a valve becomes stenotic, meaning narrowed and stiff, the heart must work harder to push blood through the restricted opening. This extra workload stresses the chamber upstream from the valve. When a valve becomes regurgitant, meaning leaky, blood flows backward with each beat. The heart must pump the same blood multiple times to achieve forward flow. This inefficiency increases workload and gradually exhausts the heart muscle. Lung conditions and blood clots can stress the right side of the heart specifically. Diseases that destroy lung tissue or constrict pulmonary blood vessels increase the resistance the right ventricle faces. Blood clots that travel to the lungs block vessels and further raise this resistance. The right ventricle, which has thinner walls and less reserve than the left, can fail under this sustained pressure. One of the tragic aspects of heart failure is that the heart has limited ability to heal itself. Your body contains different types of cells with different capacities for regeneration. Some cells, like those lining your gut, divide constantly and can replace themselves completely within days. Other cells, like those in your liver, divide rarely but can do so when needed, allowing the liver to regenerate substantially after injury. Heart muscle cells fall into a third category. They divide extremely rarely in adulthood. When heart muscle dies, it is replaced by scar tissue rather than new muscle. The damage is essentially permanent. This is why heart attacks matter so much. This is why preventing heart damage is so much more effective than trying to reverse it. The heart you have is largely the heart you will always have. Cells lost are not replaced. Function lost is not regained. Treatment can help the remaining muscle work more efficiently, can reduce the burden it faces, can slow further decline, but it cannot regenerate what has been destroyed. Heart failure progresses through stages, from mild to moderate to severe. In early stages, the heart compensates for its weakness. It beats faster to maintain output. It enlarges to hold more blood per beat. Hormonal systems activate to retain fluid and constrict blood vessels, maintaining blood pressure despite reduced pump function. These compensations work for a time. The person may feel relatively normal, unaware that their heart is struggling beneath the surface of their daily life. As the disease advances, compensation becomes inadequate. Symptoms emerge: breathlessness with exertion, then at rest; fatigue that seems disproportionate to activity; fluid retention that manifests as weight gain and swelling. These symptoms reflect the heart's inability to keep up despite its best compensatory efforts. The traffic jam of blood backing up behind the failing pump produces congestion that the body cannot hide. Cardiologists measure heart function using a metric called ejection fraction. This represents the percentage of blood in the left ventricle that is pumped out with each contraction. A normal ejection fraction is roughly 55 to 70%, meaning more than half the blood in the ventricle is ejected with each beat. As the heart weakens, ejection fraction falls. 40 to 55% indicates mild impairment. Below 40% indicates moderate to severe impairment. Below 30% indicates advanced disease with significantly compromised function. Ejection fraction is not a perfect measure. Some forms of heart failure occur with preserved ejection fraction, where the percentage pumped is normal, but the heart is still failing because it cannot fill adequately between beats. But for most people with heart failure, ejection fraction provides a useful indicator of severity and helps guide treatment decisions. The congestion that defines heart failure produces symptoms that are predictable once you understand the underlying mechanics. Lung congestion produces breathing difficulties. Fluid in the lung tissue interferes with oxygen exchange. The person feels short of breath, initially during exertion when oxygen demands are high, later at rest as congestion worsens. Lying flat redistributes fluid into the lungs, which is why breathlessness often worsens at night and why people wake gasping in the dark. A cough may develop, sometimes with frothy or pink-tinged sputum as fluid accumulates in the airways. Wheezing can occur as the airways narrow from the surrounding fluid. These respiratory symptoms are sometimes misattributed to lung disease when the actual problem is cardiac. Systemic congestion produces swelling and fluid accumulation throughout the body. The legs and ankles are typical sites because gravity pulls fluid downward. By evening, after a day of upright activity, the swelling is often most pronounced. Overnight, with the legs elevated, the fluid redistributes and the swelling may decrease, only to return the next day. Rapid weight gain, several pounds over a few days, often reflects fluid retention rather than true tissue gain. People with heart failure are often instructed to weigh themselves daily and report sudden increases, which can indicate worsening congestion before other symptoms emerge. The liver can become congested when right-sided failure causes blood to back up into the systemic veins. The liver swells and may become tender. Its function can be impaired, affecting metabolism and producing digestive symptoms. The abdomen may accumulate fluid, a condition called ascites, that produces bloating and discomfort. Fatigue and weakness result from inadequate oxygen delivery to muscles and organs. When the heart cannot pump enough blood forward, tissues receive less than they need. Energy production falters. The person feels exhausted in a way that rest does not fully relieve. Simple activities that once required no thought now require effort and recovery. The heart rhythm may become irregular as the stressed heart develops electrical disturbances. Atrial fibrillation, where the upper chambers beat chaotically, is common in heart failure and further compromises efficiency. Palpitations, the sensation of abnormal heartbeats, may be felt as fluttering or racing in the chest. Cognitive symptoms can develop as the brain receives inadequate blood flow. Confusion, difficulty concentrating, memory problems, these can accompany advanced heart failure and are sometimes the symptoms that most distress patients and families. The kidneys, which depend on adequate blood flow to filter waste, often struggle in heart failure. Urine output may decrease. Waste products may accumulate in the blood. The kidney dysfunction can compound the heart dysfunction in a vicious cycle where each organ impairs the other. Understanding these symptoms matters because early recognition leads to earlier treatment, and earlier treatment generally produces better outcomes. The progression of heart failure can be slowed when intervention occurs before the heart has remodeled extensively, before scar tissue has replaced muscle, before compensatory mechanisms have exhausted themselves. Many people delay seeking care because they attribute their symptoms to aging, to being out of shape, to other conditions. This delay costs time that cannot be recovered. Management of heart failure involves lifestyle modifications, medications, and in some cases devices or surgical interventions. Let me walk through each domain. Lifestyle modifications focus on reducing the burden on the heart and preventing fluid accumulation. Diet plays a significant role. Sodium causes the body to retain water, which increases blood volume and worsens congestion. People with heart failure are typically advised to limit salt intake, reading labels carefully and avoiding processed foods that contain hidden sodium. Fluid intake may also be restricted in some cases, particularly when congestion is severe. Physical activity, which might seem contraindicated when the heart is weak, is actually beneficial when appropriately structured. Cardiac rehabilitation programs provide supervised exercise that improves the efficiency of the heart and skeletal muscles without overwhelming the compromised system. Regular moderate activity can improve exercise tolerance, reduce symptoms, and enhance quality of life. The heart may not fully recover, but the body can become better at using what cardiac output is available. Weight control reduces the burden the heart must support. Excess body weight increases oxygen demands and fluid retention. Losing even modest amounts of weight can improve symptoms in overweight individuals with heart failure. Smoking cessation is essential. Tobacco smoke damages blood vessels, accelerates atherosclerosis, and further stresses an already struggling cardiovascular system. Continuing to smoke while the heart is failing is adding insult to injury. Alcohol moderation or abstinence may be recommended, particularly since alcohol can directly weaken heart muscle and interact with heart failure medications. For some people, alcohol consumption contributed to their heart failure, and eliminating it is necessary for any hope of improvement. Daily weight monitoring serves as an early warning system. Weighing yourself at the same time each morning, in the same clothes, on the same scale, allows you to detect fluid accumulation before it produces obvious symptoms. A sudden gain of 2 or 3 pounds over a day or two often indicates worsening congestion and prompts contact with your healthcare provider before the situation deteriorates further. Medications form the backbone of heart failure treatment. Several categories address different aspects of the syndrome. Diuretics help the kidneys eliminate excess fluid, relieving congestion in the lungs and body. They are often the medications that produce the most immediate symptom relief. When congestion is severe, intravenous diuretics in the hospital may be necessary to remove accumulated fluid. For ongoing management, oral diuretics are taken daily, with doses adjusted based on weight and symptoms. ACE inhibitors and ARBs block hormonal systems that contribute to heart failure progression. These medications reduce the workload on the heart, lower blood pressure, and help prevent further remodeling and dilation. They have been shown in numerous studies to improve survival and reduce hospitalizations in people with heart failure. Beta blockers slow the heart rate and reduce the force of contraction. This sounds counterintuitive, using a medication that makes the heart beat less forcefully when the heart is already weak, but the effect is protective. Beta blockers reduce the heart's oxygen demand, prevent harmful remodeling, and improve long-term outcomes, even though they may initially make symptoms slightly worse before they improve. Additional medications may be added depending on the specific characteristics of each case. Mineralocorticoid receptor antagonists block hormones that promote fluid retention and scarring. Newer agents like SGLT2 inhibitors, originally developed for diabetes, have shown remarkable benefits in heart failure regardless of diabetes status. Antiarrhythmic medications may be needed if dangerous rhythm disturbances develop. Devices can supplement failing hearts in various ways. Pacemakers correct abnormally slow heart rhythms and, in specialized forms, can coordinate the contraction of the left and right ventricles to improve efficiency. This cardiac resynchronization therapy helps when the heart's electrical system has become disorganized by the remodeling process. Implantable cardioverter defibrillators monitor the heart rhythm and can deliver shocks to terminate dangerous arrhythmias that might otherwise cause sudden death. Heart failure increases the risk of such arrhythmias, making these devices potentially life-saving. Ventricular assist devices are mechanical pumps that can partially or completely take over the work of a failing ventricle. They are surgically implanted and powered by external batteries. They may be used as a bridge, supporting the patient while they wait for a heart transplant, or as permanent therapy in people who are not transplant candidates. Heart transplantation remains the definitive treatment for end-stage heart failure, replacing the failing organ with a healthy donor heart. However, donor hearts are scarce, and not everyone qualifies for transplantation. Age, other medical conditions, and the ability to comply with complex post-transplant regimens all affect candidacy. The goal of all these interventions is not necessarily to cure heart failure, but to slow its progression, relieve symptoms, improve quality of life, reduce hospitalizations, and extend survival. For most people, heart failure is a chronic condition that requires ongoing management rather than a problem that is solved and then forgotten. The heart may not fully recover, but much can be done to help it function as well as possible for as long as possible. This brings me to perhaps the most important point: the role of the patient in managing this condition. Heart failure is not something that happens to you passively while you wait for doctors to fix it. It is a condition that requires active participation, daily attention, and informed decision-making. You must take medications consistently, even when you feel well, because the benefits of these medications often occur through preventing progression rather than producing immediate symptom relief. Missing doses or stopping medications because symptoms improve can allow the disease to advance. You must monitor yourself, weighing daily, watching for worsening symptoms, recognizing when something has changed that requires medical attention. Early intervention when congestion begins to worsen is far more effective than waiting until you are severely short of breath and need hospitalization. You must make lifestyle choices that support your heart rather than stress it. Diet, activity, weight, smoking, alcohol, these are not optional considerations when your heart is failing. They are essential components of your treatment plan that you control directly. You must understand your condition, knowing why you take each medication, knowing what symptoms to watch for, knowing how heart failure progresses and what the warning signs of deterioration look like. All of this knowledge empowers you to participate actively in your own care. Heart failure is common. Millions of people live with it. Advances in treatment over recent decades have dramatically improved outcomes for many of them. Medications that did not exist a generation ago now routinely help people live longer and feel better. Devices that were experimental have become standard. Surgical techniques have become safer and more effective. But treatment is not magic. It works best when patients understand their condition, follow their regimens, and partner with their healthcare providers in an ongoing process of monitoring and adjustment. The heart that is failing did not fail overnight. It weakened gradually through processes that may have been invisible for years. Stabilizing that heart and slowing further decline is similarly a gradual process, measured in months and years of consistent effort. The climb up the stairs that left you breathless was a message. The night you woke gasping was a message. The swelling in your ankles, the unexplained weight gain, the fatigue that sleep could not cure, all of these were messages from a heart that was losing its ability to sustain you. Those messages were not meant to frighten you into paralysis. They were meant to prompt you toward understanding and action. The heart that beats inside you has been working since you were a cluster of cells. It has sustained everything you have ever done. Every breath, every thought, every movement. It has asked for nothing except blood through its own coronary arteries, yet it has given everything that life requires. When that heart begins to fail, it deserves your attention, your understanding, and your commitment to doing what can be done to support it. Some damage cannot be undone, but progression can be slowed, symptoms can be managed, quality of life can be preserved, years can be added to a life that might otherwise have been cut short. The stairs do not have to defeat you. The nights do not have to be spent gasping for air. The swelling does not have to progress until your shoes no longer fit. These outcomes are not inevitable. They are what happens when heart failure goes unrecognized, untreated, or inadequately managed. With recognition, treatment, and management, a different future is possible. Your heart is failing slowly. But slowly means there is time. Time to understand, time to intervene, time to change the trajectory. What you do with that time determines what happens next.